So today's lecture is absolutely fantastic. We have Dr. James Fang joining us to speak on one of the really hot topics, certainly in heart failure. He's the chief of cardiovascular medicine, University of Utah School of Medicine, and director of the cardiovascular science line at the University of Utah Health Center. And he holds the John and June Hartman Presidential Endowed Chair as a professor of medicine, University of Utah. Dr. James Fang is the president-elect of the Heart Failure Society of America in recognition of his expertise and leadership. And I was fortunate enough to be program co-chair with Javed Butler for the Heart Failure Society of America program. And it was actually, sort of astounding that James' name comes up, whenever we put any kind of a component of the program together, because people always want to hear more from him because of his command of the subject and also scientific insight and clarity. And the latter probably is not accidental, because he actually was trained as a scientist, having graduated from Duke University with degrees in both mathematics and chemistry. So that's real science here. And then he received his medical degree from Duke University School of Medicine. He then did his internship and residency at Johns Hopkins Hospital and selected as a chief resident during his senior year. Then undertook cardiovascular as well as heart failure transplant fellowship at the Brigham and Women's Hospital at Harvard in Boston. And obviously they liked him because after his training, he was recruited on staff and stayed at Brigham and Women's for the next decade. He served as associate professor of medicine, medical director of a heart transplant program, and also the program director of the cardiovascular fellowship training program during his tenure in Boston. And in 2006, he was recruited to University Hospital Case Western, and in Cleveland as the chief of cardiovascular medicine and also associate chief of clinical affairs, medical director for the heart failure transplant and circulatory assist program at the Harrington Heart and Vascular Institute. And then most recently in 2013, was recruited to be the chief of cardiovascular medicine at the University of Utah. And Dr. Fang's leadership continued to push the University of Utah as a prominent clinical educational research institution for cardiovascular disease. I think there's no question he's done that, but he's also pushed forward on a number of innovative thinking in the field of heart failure, and continue to re-examine how we actually think about heart failure, both as a disease that is certainly a major burden in terms of the health system, but also how to actually better treat our patients. And we're absolutely privileged today to have Dr. James Fang this morning as our esteemed speaker. His title is Heart Failure with Preserved Ejection Fraction, Heart Failure or Renal Failure, an update. Looking forward to it, James.
Thank you, Peter. It's a real honor to be here. I've known Peter and his work for many, many years, and this is my first trip to Ottawa, so it's fantastic. Well, let's get started. These are my disclosures. So what I'm going to try to pitch to you is something that's bothered me since, frankly, I was an intern, which was in 1988, which is a little while ago, but I hope to update you about where this hypothesis stands, as I had written about this a few years ago in Circulation. I think everybody here in the room recognizes the challenge with this particular disorder. Obviously, as the population's aging, as comorbidities are really running rampant, this is a problem for all of us. I'm not going to talk a lot about this, but we can certainly offline, is making the diagnosis isn't as easy as it might appear to be, at least in the literature. And then, of course, when I was an intern in 1988, my attending physicians used to say this condition never really kills anybody. So, don't worry about it. I think that thinking has changed quite a bit as well. And so it really has a large societal burden. Unfortunately, we've not had the kind of progress we would have liked. All of you are familiar with HFrEF, heart failure with reduced ejection fraction, and we've made huge strides in that. This is a timeline of the clinical trial effort, randomized clinical trial effort in the HFpEF space. As you can see, this goes back some 20 years, and we've tried a lot of different things here, color-coded on the far right. Of course, lately there's been this explosion of other agents, unfortunately, most of which have been negative. We can talk a little bit about sacubitril valsartan at the end. Everybody knows about the p-value controversy there. But probably what's really brought the issue of HFpEF to light recently, and this is why there's a lot of talk here, are the SGLT2 inhibitor trials, and we'll talk a little bit more about that in just a moment. But, you know, when I gave this talk a few years ago, this was, you know, how I really formulated my thoughts. And, you know, we kept coming up with failure after failure after failure. And when you do clinical trials, the questions are, you know, why were they failing? You know, first of all, were we enrolling the wrong patients? I was a CHARM investigator. CHARM was the candesartan in heart failure trial. And we were encouraged to make sure they had quote unquote heart failure, but we saw a lot of short of breath people with normal ejection fractions. And so there was always this tension about, were we really enrolling the right patients? Number two, you know, heart failure, we're going to get a little more into this, is neurohormonal antagonism really the right therapeutic strategy? Maybe we've been barking up the wrong tree. Were we looking at the wrong endpoints? At the end of the day, these patients are very complicated, a lot of comorbidities, and it's not just cardiovascular endpoints that matter. And then perhaps most importantly, were we simply just addressing the wrong target? Well, what's changed in our thinking lately? Well, I don't know, as a clinician, I tend to be a lumper than a splitter. That means I like to try to keep it simple. Unfortunately, the paradigm in at least HFpEF is make it more complicated. And the idea here really started with Sanjeev Shah and this work, where he took a group of 500 plus patients, extremely well phenotyped at Northwestern, and then using machine learning was able to come up with different categories of these patients. And these patients segregated by their outcomes, as you can see here. And I reviewed this paper for Circulation, and my biggest problem with the paper was there was no sort of pathophysiologic construct behind these patterns. A computer was able to split this out according to this mortality difference, but it was hard for me to put anything together as why this was happening. And the idea that the heart is central to HFpEF has come under more duress. This is work from Ben Levine's group at UT Southwestern, just published a couple of weeks ago, where he examined the exertional tolerance of HFpEF patients relative to lowering of the wedge pressure. So I think all of us recognize that an increase, either spontaneous or provocable increase in the wedge pressure, is quote unquote diagnostic of HFpEF and the ejection fraction is normal. Well, it should follow, if that's the exertional limitation, then bringing it down acutely should make you be able to go further. Well, he did that with nitroglycerin, as you can see here along the x-axis, but there was no relationship of bringing down the wedge to your exertional tolerance. Sort of begging the question, how fundamental was the heart to the issue? And maybe actually the increase in wedge pressure was simply an epiphenomenon and perhaps not central to the whole pathophysiology. So, you know, it's worth standing back for a minute. And this is, of course, the late Robin Williams, one of my favorite comedians, who's providing a different perspective to the thinker here. And I think this is really apropos in this particular condition, because fundamentally, the human heart doesn't hang on to salt and water. And I think congestion, as we're going to talk about, is so central to this disorder. You have to make a case why there is congestion. And this really, for me, came together when we started looking, when I was at Case Western, at the outcomes of patients who had recovered their ejection fraction. So these were patients whose ejection fractions were less than 40 or 50%, and now was greater than 40 or 50%. We just wanted to know what happened to these people. I think every one of you have these patients in clinic. And what we noted, which you can see here, in the, let's see, let me just make sure, in the green line, is that certainly their outcomes are better than those patients with persistently reduced ejection fraction or HFpEF. But the point is that there is still an event rate in these patients, despite the recovery of the ejection fraction. And so it got me thinking, why were these people being admitted? Well, 90% of people who get admitted with heart failure get admitted with what? Congestion. So why is there a congestion if the ejection fraction has recovered? And in fact, we also know that these patients have a mortality too, despite recovery of their ejection fraction. Well, if you're a clinical trialist, at the end of the day, when you enroll patients in clinical trials, you want to make sure they have the syndrome. Well, I've used the entry criteria on the far left in an old HFpEF trial, and on the far right, a more contemporary HFpEF trial. In both instances, you'll see that you have to have signs and symptoms, and the sign is almost always congestion, either physical exam evidence or natriuretic peptide evidence, which is a surrogate, frankly, of congestion and volume overload. Now, of course, you have to have an echocardiogram that shows preservation of ejection fraction. And in general, you have to have some abnormality of the echo. There has to be left atrial enlargement, LVH, pulmonary hypertension. There has to be something on the echo that might suggest the heart is at play here. But at the end of the day, it's this issue of congestion. And of course, congestion is the marker of mortality and progression of the disease. And we see this here. This is work from Greg Fonarow, which just shows you that in hospitalized patients, the outcomes are very poor at 5 years, regardless of ejection fraction. So again, the primacy of congestion in this disorder cannot be ignored. And if at the end of the day, you're a lumper rather than a splitter, the issue is congestion, congestion, congestion. It's the final common pathway, right? And in fact, in our guidelines, and I had the privilege of being the guideline committee for the American Heart Association, the ACC, the only thing we could agree upon in terms of treatment of HFpEF were diuretics, which is in green here. Now, we're going to talk a little bit more about SGLT2 inhibitors. We'll tell you a little bit more about why it wasn't a class 1 indication, which it will be in the next update. But at the end of the day, everybody agrees it's congestion, congestion, and congestion. So here's the dilemma. This is a disorder that really today largely remains unexplained. There are multiple observations that have suggested heterogeneity and multiple mechanisms. But it doesn't really matter about the mechanisms that describe some of the exertional intolerance, because there's a lot of evidence, for example, for peripheral oxygen utilization. There are issues with myocardial metabolism. It really doesn't matter which mechanism you employ. None of us as clinicians actually even call it heart failure until you give Lasix. Yet the fundamental cause of the avidity for salt and water remains largely explained. And I'm going to show you some data that we've been able to generate to get at this issue. So this is the usual paradigm for heart failure, that there has to be something that happens to the human heart, myocardial infarction, myocarditis, wide open mitral regurgitation. There has to be something at the end of the day that leads to ventricular dysfunction and activation of neurohormonal pathways, traditionally the RAS system and the adrenergic nervous system. And once that occurs, at least teleologically in the short term, you want preservation of blood pressure and output, and that leads, of course, to vasoconstriction and maintenance of central pressures. But unfortunately, this leads to the kidney to become sodium fluid avid, and you get this sort of vicious cycle with more volume and more remodeling and more adrenergic stimulation, and et cetera. And so the paradigm here, at least in HFrEF, is to do what? Is to block this. Well, if this is the paradigm for heart failure, these three things should be true. There should be some sort of stimulus for the neurohormonal activation that starts with the heart. It is heart failure at the end of the day. Number two, the activation should be demonstrable. And then, of course, three, if you block it, things should get better. So let's look at these three key issues if the heart is primarily responsible in this condition. Well, this is hemodynamic work from Barry Borlaug's lab, and this has been reproduced by the Japanese and other groups. We're simply looking at the hemodynamics in patients with HFpEF. And you can see here vascular function on the upper left, and VA coupling on the lower right. You see control on the far left, hypertensive controls in the middle, and HFpEF patients on the far right. And what I want you to really concentrate on is the very last row, which is cardiac index. It's all the same, all right? Number two, if you look at actually systemic vascular resistance, which is about 3 rows down, you can see that that's all the same. There really is no primary stimulus, hemodynamic stimulus, at least in these group of patients, to activate the neurohormonal system, right? There should be some abnormality in at least the vascular filling and or the output to suggest the heart was the primary mediator of the salt and water retention. Okay, let's take point number 2. Well, let's say we just haven't found the right cohort of patients to prove this in, that these were all biased studies. Well, we should at least find a data set that can suggest there's neurohormonal activation. This is work from the SOLVE trial from John McMurray. What you see here is plasma norepinephrine on the left, plasma renin activity on the right. The bars represent controls in the dark bars, HFpEF in the clear bars, and the hatched bars is HFrEF. And I think from the back of the room, you can appreciate that although there may be some modest neurohormonal activation, it's pretty underwhelming. Well, let's move on to the intervention, right? We talked about the primacy again of adrenergic activation and renin activation in this syndrome. Well, antagonizing these things should work. Well, there are no large-scale beta blocker trials that are randomized in this space. This is observational data from Lars Lund from the Swedish heart study. What you can see here, if you ignore the yellow bar, which are unadjusted, you can see there is really no difference in patients with HFpEF in this propensity analysis when given beta blockers. Well, how about the RAS system? One of the largest HFpEF trials to date, published in the New England Journal a number of years ago, is the iPreserve study. This is a study of irbesartan, randomized to placebo in the management of HFpEF. And this is a little hard to read, and I apologize for that, but I just really want you to concentrate on one row, and that's hospitalizations for worsening heart failure. Now, I think everybody recognizes in this trial, this was a neutral trial, but if you specifically look at hospitalizations, which again, we talked about are driven by congestion, no difference in the outcome, absolutely no difference in the outcome. Moreover, you can't find a subset of patients that might have benefited. For example, you might say, oh, it was the patients that had never been on an RAS antagonist that might benefit. No, we couldn't find it. And then again, we know actually, at least in HFrEF data sets, that when you see a bump in the creatinine, right, or a lowering of the GFR, we anticipate that, right, when you give lisinopril or losartan, we anticipate that. And that, in fact, is usually what? A marker for a good outcome. You actually want to see the creatinine bump a little bit when you give an RAS antagonist. We know that portends actually survival benefit of this class of drug. In contrast, in HFpEF, seeing that finding of a bump in the creatinine or acute lowering in the GFR over a couple of weeks actually portends a worse survival, suggesting perhaps what the drug is doing is unmasking an underlying renal problem. So, you know, it just really begs the question, are we really talking about heart failure at the end of the day? This is a cartoon taken from Barry Borlaug and Maggie Redfield from a number of years ago, more than a decade ago, where they examined the outcomes of patients with HFrEF and HFpEF randomized to neurohormonal antagonism. And you can see here in the red is there is really no benefit of traditional neurohormonal antagonism, in contrast to the blue, where you can see an improvement of the outcomes randomized to these drugs. So at the end of the day, is this really just a syndrome of volume overload? This is a very famous paper from Bob Schreier and Bill Abraham from the New England Journal a number of years ago about cardiorenal syndrome. And the reason I put this up is because you can see what direction are all the arrows. They're all going to the kidney. This has been one of our big biases that the kidney is quote unquote simply just a manometer of what's going on and not really participating in the pathophysiology of cardiovascular disorders, I would argue that most of these arrows should be going away from the kidney rather than to the kidney, and that the kidney is playing a fundamental role in syndromes like this. And I won't tell you the author of this chapter because it's a good friend of Peter and I's, but I gave him a hard time because when I went to his textbook, which I'm sure all of you know, the Brownwell textbook of heart disease, this is literally a quote out of the chapter in heart failure. There is little evidence to suggest that a primary renal abnormality is responsible for excessive sodium retention in heart failure. And so all of this is actually one of the classic textbooks. And I haven't asked the author of this about, when I did show this to him, he said he would be revising appropriately the chapter as the evidence would support. So I'm trying to make a case for the kidney. If sodium and fluid avidity, or its lack of ability to excrete sodium and fluid, is not being driven by neurohormonal stimulation, which was proximally incited by the heart, then perhaps the kidney must be doing it inappropriately, so to speak. Thus, perhaps the congestion of this disorder is really a kidney problem rather than a heart problem. So these are the 5 lines of evidence, or 5 to 6 lines of evidence that I would suggest to you that support that it's a kidney. I think I've tried to make a case why it's really hard to implicate the heart. Number 1, renal insufficiency is common in HFpEF and associated with outcomes. There's a tremendous amount of epidemiologic evidence to support this. We're not going to review it all. Number 2, renal function is inadequately characterized by measures of glomerular filtration. We'll talk a little bit more about this and what this means. It's not just about the creatinine or the calculated EGFR. Renal insufficiency, importantly, can presage HFpEF. A lot of data sets here to support that. Renal insufficiency in and of itself can mediate cardiovascular dysfunction. All of you have taken care of a dialysis patient. Their hearts are never normal. And then 3, the issue of just being salt and fluid overloaded is actually critically important to the perpetuation of cardiovascular dysfunction, as we'll show you. Okay, this is just one of many epidemiologic studies that support the idea that there's a relationship independent between CKD, chronic kidney disease, and renal insufficiency. This is work from several large insurance databases in the United States. And you can see here the EGFR falling on the in the far left column. In the middle is HFrEF, and the far right column is, no, I'm sorry, in the middle column is HFpEF, and the far right column is HFrEF. And you can see, obviously, that there is a very important independent association. Almost by the time you get down to GFRs that are less than 30, we're talking about a 2-fold increase in the prevalence and incidence of heart failure. Well, let's move on to issue number 2, because I think everybody here in the room recognizes the first observation. Renal function is inadequately characterized by measures of glomerular filtration. So again, in 1988, I assessed renal function on the wards with the serum creatinine, occasionally the BUN, urine output, and maybe a renal ultrasound. And if a house officer was good, you did what? You checked a UA. It's 2023. 45 years later. How do you guys assess renal function on the wards? Let me guess. Serum creatinine, EGFR, BUN, urine output, maybe renal ultrasound and UA. And can you imagine, Peter remembers this, 45 years ago in cardiology, we used to do M-mode echo. I don't think half the room even knows what M-mode echo is. So in 4 or 5 decades, at least, our appreciation of the intricacies of renal function is relatively primitive. What is the evidence to suggest this? Well, I hate to bash nephrology. I don't see any nephrologists here, but maybe you are. There are ways of actually looking at renal function a little bit more carefully. This is work from the JISI trial. Remember the JISI trial, large European trial of using statins as well as fish oil in a 2x2 factorial randomized design. And the investigators in Italy here were thinking way ahead of the game. They started to use tubular markers of renal injury, things like NGAL, KIM1, NAG. These are can be collected in the urine or the plasma and indicate renal injury. And what they did is simply look at outcomes of the patient segregated by what I would argue more subtle evidence of renal dysfunction. As you can see that when you take the eGFR, markers of tubular injury, and glomerular injury, for example, like albuminuria, which I do think that we should all be doing much more frequently, you can see that outcomes do segregate quite well according to more subtle measures of renal insufficiency and not simply just the presence or absence of CKD. Moreover, don't forget that sodium fluid avidity occurs very early in heart failure, and this is HFrEF, even before you see a change in the eGFR. And this is work in Italy. We've done the same work in our HFpEF patients, where you can see here on the far left, at the top left is GFR, renal plasma flow, and renal vascular resistance. And what you see on the far left are normal subjects. On the right, what you see are patients with heart failure. And in this situation, these patients were given the sodium load, and you can see what happens when you give normal controls or mild heart failure patients, what happens to their GFR and their renal plasma flow and the renal vascular resistance when you give them the same sodium load, right? There's more filtration, et cetera, really no different than controls. Well, what's really fascinating is what happens to the renal response. And by the way, these patients' eGFRs are all quote unquote normal. You guys couldn't tell by just looking at the eGFR that they would have this very demonstrable differences in what they do with the sodium. On the far right, you can see the patients in the black bars, what happens to their fractional excretion of sodium, water, and potassium. And you can see this on the far right, the bars go down rather than up, as in the control patients in the clear bars. So there's some abnormality of tubular dysfunction that's going on that's not reflected in the serum creatinine or the estimated GFR. And this is really fundamental because on rounds, none of us ask ourselves, well, what are the tubules doing, right? All you do is ask, what is the glomerulus doing with eGFR? We did the same thing, actually, at the University of Utah with a small group of patients. We basically just recapitulated that same study. We gave about half a liter to a liter of saline to patients with HFpEF with eGFRs. By the serum creatinine here was 1.2, by the way, something I think none of you in the room would probably even think twice about. And you can see here in the dark bars are the controls, and in the light bars are the HFpEF patients. And you can see on the far left, you can see the total amount of saline that we gave, which is about the same. And then on the next three panels, you can see what happens to the total urine output, the proportion of sodium that was infused, that was excreted, and then the far right, the totally excreted amount of sodium. As you can see, they're sodium avid. And these were stable HFpEF patients. These are outpatients that had not been previously hospitalized in the past year. You might ask yourself, well, where is the defect? We actually looked at this ratio of urinary cyclic GMP to the plasma BNP as a measure of natriuretic peptide efficiency. And as you can see that our patients who had HFpEF on the far right had very low levels of cyclic GMP in their urine when normalized for their plasma BNP, suggesting a hyporesponsiveness of the HFpEF kidney to natriuretic peptides. So perhaps a mechanistic insight as to why, despite a GFR that's not very impressively low, that they're hanging on to salt and water. Well, let's get on to this other piece of evidence that would suggest that, in fact, this is more of a renal disorder than cardiac disorder. The obvious issue is if you have some degree of renal failure, that it might presage the development of this syndrome. Well, this is work from the Netherlands. This is a large group of patients, almost 10,000 patients in the very now well-studied PREVEND registry. These were patients that were aged 28 to 75 with some baseline and very modest amounts of urinary albumin excretion. And they followed these patients in this community for almost a decade. And then they simply looked at the incidence of HFrEF in the middle column, HFpEF in the far right column, and looked at various risk factors. And no big surprise, age, of course, is a risk factor for heart failure. as is being male, as is coronary disease and smoking. But what I point you to is actually measures of renal function, which are the cystatin C and the urinary albumin excretion. I pointed this out to you here with the arrow, that this abnormality in cystatin C, which I think everybody now agrees upon is probably a better measure of renal function than using serum creatinine, presaged the development of HFpEF, in contrast to HFrEF. So let's move on to another issue. And there are other data sets that look at that too. So let's look at this other issue, that renal insufficiency in and of itself can mediate cardiovascular dysfunction. Again, we talked a little bit about this before. All of you have taken care of a patient with dialysis. They never have normal hearts. But short of dialysis, there are a lot of things that we can see that suggest that the renal insufficiency in and of itself can produce cardiac dysfunction. This is, again, work from Sanjeev Shah from Northwestern that looked at echocardiographic changes that were that accounted for all of the other comorbidities and the potential confounders in this relationship, and noted that there was a relationship between left atrial size and mechanics and the EGFR here done by CKD stage. And then, of course, we know that patients with CKD, even subtle abnormalities in EGFR can develop vascular stiffness. On the left here, you see compliance, and you see EGFR on the left, and you see urinary albumin creatinine ratio, again, as measures of CKD. And as you can see, as the EGFR declines and the urinary albumin excretion increases, that there is less compliance of the vessels and they get stiff. On the far right, you see the inverse of this, which is pulse wave velocity. So as your blood vessels get stiffer, pulse wave velocity increases, and no big surprise here, that is your renal function gets worse, your blood vessels get stiffer, and this is exacerbated in the setting of diabetes, which you see here in the clear bars. So probably the elephant in the room is, well, what is it that the kidney is not getting rid of that's producing this problem? And Peter and I were just talking about this. So, the kidney really has four functions that, in daily clinical practice, you don't really think about assessing on the basic metabolic panel, do you? So, obviously we think about things like waste products, but the only waste product you're really measuring is the blood urea nitrogen on the basic metabolic panel. Acid base, we usually don't even think about acid base. Look at the CO2 on the basic metabolic panel, but it's not much more sophisticated than that. Of course, salt and water is generally obvious from the physical exam, but there are just a number of functions, including the kidney as a hormonal organ, are just not assessed in clinical practice. But this issue of waste products is fascinating because these are just some of the mediators that have been reported in the literature that may have a role in producing cardiovascular dysfunction. And none of these are measured in clinical practice, but there's actually a pretty strong evidence base that each one of these contributes to vascular stiffness, myocardial stiffness, and fibrosis and dysfunction. So a lot of potential possibilities. I do think it's going to probably be hard to target each one of these specifically, but as Peter and I just talked about, can you get upstream of some of these things to prevent the cardiovascular consequences of subtle renal insufficiency? Well, what I'd love to talk really about is how dangerous it is simply to have salt and water overload. It's not just the big heavy legs and the patient telling you they have orthopnea and PND. There are many other pathophysiologic issues with distending blood vessels. So when you take a blood vessel, by the way, vein or artery, and you distend it with increased plasma volume, you end up affecting a very important organ called the endothelium, which is the source of a lot of dysfunction in the just general milieu of the human body. So and I'm going to show you some evidence where just distending blood vessels and having interstitial volume produces generalized inflammation, oxidative stress, obviously the elevation of CVP. It's going to impact renal function. It's going to stiffen arteries, Of course, one of the reasons we use diuretics for hypertension is because of the hypertensive consequences of vascular overload. And then, of course, it's a pretty potent stimulus of adrenergic activity. And this is one of the reasons why, for those of you who round on patients after cardiac surgery, 20, 30 years ago, we used to have patients, most patients would gain 5, 10, sometimes more pounds after cardiac surgery, and we kind of just lived with it. Now, most of you recognize, if you're on the units, we are pretty aggressive about getting the volume off, because I think cardiac surgeons and surgeons have realized over the years that just having this massive volume overload is really bad for the patient. And so we're much more aggressive. And this is why in your cardiac surgery units, you probably are like, I've never seen so much dialysis or CRT so quickly. And we're doing this now because we recognize that just having salt and water overload is so detrimental. So this is one of my favorite studies from Nir Uriel, who just wanted to prove in normal controls, these were, I think, 35-year-old patients without any other issues, about what happens to just a vein when you distend it. So what he did was he congested the vein by putting a tourniquet on the arm just to occlude the venous backflow. So you would get venous congestion. And then what he did was measured in the other arm a number of inflammatory mediators and measures of endothelial dysfunction. And perhaps no big surprise that here in the test arm on the far right, you could see that there was activation of inflammatory markers and also markers of endothelial dysfunction, such as endothelin-1 and VCAM. In animal models, by just producing a high salt diet, you're also, and we don't think about this very much, but volume overload and salt overload also results in glomerular dysfunction. This is a mouse study in which animals were given high saline diets and normal saline diets. And you can see, and then nephrectomized. And as you can see that here in the middle panel, if you can see it in the bottom row in the middle, you have a nephrectomized animal given high saline diet, that the glomerulus becomes what? Small and shrunken. There's glomerulosclerosis in contrast to the control animals. And I think very importantly, you could block this finding by giving adapamide, giving a diuretic, which you see on the far right. And you can see the glomerular score on the figure on the far right that simply demonstrates that this could be blocked by simply blocking the salt overload. So, okay, that is just some of the evidence that would support that the kidney is fundamental. What are really the therapeutic implications? We're not going to transplant patients. I can show you, by the way, some transplant data that has looked at this. Well, as clinicians, like, so what? Okay, I kind of knew that. I've been giving diuretics for this problem for a long time. Am I really fundamentally impacting what's going on? Well, I think there are three important therapeutic implications of this paradigm. They include the real importance of controlling sodium and fluid avidity early on, where it may not, by the way, be physically apparent to you. Number two, we're not nephrologists for a reason, but I think anytime you're in clinic, you need to be thinking about, the kidney and how to slow its progression. All of you give statins like candy, right? To prevent the progression of atherosclerosis. Well, you should be thinking about in your practices, how can you slow the progression of renal insufficiency? And then we're going to talk a little bit more about the fact that perhaps the paradigm shift here is thinking more about the neighborhood. You're only as good as the neighborhood you live in. And that's true of every organ in your body. The brain, the heart, the kidney, and the liver are only as good as the systemic milieu that it lives in. And we'll talk a little bit more about that too. So this issue of controlling salt and fluid avidity is really important. This is work from Scott Hummel at Michigan, done a number of years ago. And what he did was take some HFpEF patients who had been admitted with heart failure and then gave them a pretty significant salt restriction, the DASH diet, which many of you are familiar with. And he did this for 21 days. And in this modest group of patients, I think this was 16 patients, what he looked at was the blood pressure in clinic, the ambulatory blood pressure, the pulse wave velocity as a measure of vascular stiffness, urinary isoprostanes as a measure of inflammation, and then urinary aldosterone just to see if they were really salt restricted. And you can see what happens before in the middle column and after in the far right column. First of all, there's an improvement in blood pressure because the plasma volume, which was not measured, but presumably went down with salt restriction. You can see the carotid femoral pulse wave velocity improved. It got slower, meaning a better compliant artery. And then there was evidence for less inflammation. And again, the increase in urinary aldosterone going up was just a reflection of the salt restriction. So that we're able, again, to control some of these things by just controlling the salt and therefore the volume of the plasma volume. Is there other data to support this idea? Well, this is now the very famous single randomized trial of the CardioMEMS device, 550 patients, class 3 heart failure, hospitalized with heart failure in the past year. And as you recall, in this particular trial, a subgroup, about 20%, had HFpEF. And you can see here that in the patients who were in the randomized to the CardioMEMS group, you can see here in the red, very quickly, right? This is before it was really evident to the clinician or the patients that had volume overload, is that when you saw an increase in the PA pressures by this device, that the clinician was treating that, and generally with diuretics, by the way, almost entirely with diuretics. As you can see, if you hop on this before the patient and the clinician are even aware of it, using invasively measured filling pressures, that you can keep people out of the hospital. One of my more, I think, more compelling pieces of evidence is taken from the ALLHAT trial. Some of you may not remember the ALLHAT trial. The ALLHAT trial is perhaps the largest hypertensive trial ever done in the world. This is 25,000 patients randomized to 4 arms, an ACE inhibitor, an alpha blocker, a beta blocker, and a diuretic. And then they just followed these patients. What you see on the left are the patients with incident HFpEF, and on the far right, you see patients with incident HFrEF. If we just start on the far right, you can see the patients in whom were randomized to ACE inhibitors or diuretics had less HFrEF. On the far left, the only bar there at the very bottom, or I said the curve that's at the very bottom, is the diuretic one. Again, prospective data from a randomized trial suggesting that control of the circulating sodium may have an impact. And then, of course, if you look at the impact of various drugs on vascular stiffness, and this is a poor man's measure of vascular stiffness, this is a pulse pressure. You may not know this, but the European guidelines suggest trying to get the pulse pressure to less than 50 as a measure of improving vascular fitness. You can see here that the diuretic HCTC has the most profound impact on lowering the pulse pressure relative to any other drug. And again, we talked about the importance of vascular stiffness in HFpEF. So another piece of evidence at controlling the volume. And this is just some work that we've done that looked at the role of spironolactone in the management of HFpEF. So this is work from the TOPCAT trial. You recall the TOPCAT trial was a trial of spironolactone versus placebo. And you could argue in a congestive heart failure trial that if you randomize somebody to a diuretic versus no diuretic, the diuretic's going to win. Well, we did see that. I won't go into the specifics about the TOPCAT trial because, you know, as everybody here in the room knows, it was a neutral trial technically, but when you restricted the outcomes to North America and not Russia and Eastern Georgia, that the trial was positive. And what we noted in this particular trial, that when you gave spironolactone, the amount of clinical diuretic the patients were on was less. And again, suggesting that maybe it was actually augmenting diuresis and working as a diuretic as much as it was working as an aldosterone antagonist. And then finally, in terms of this issue of salt water retention, I want to point something that I think all of you recognize, and that is, as you age, the adrenal cortex remodels. And it remodels into these group of aldosterone producing cells that are no longer under the control of renin. And what happens is you get autonomous hyperaldosteronism as you age. And this is just some autopsy evidence. You see at the upper left right-hand panel, C, this is changes in the adrenal cortex that are going on. The dark color is aldosterone. And this is why using MRAs is so effective in hypertension in older patients. This is why if you go to a hypertension clinic, 20-25% of the patients actually will have hyperaldosteronism because of this phenomenon. And this may explain also why we see HFpEF as a condition of aging. All right, preventing or slowing renal dysfunction. I think we recognize, and this is something that I didn't appreciate until recently, is that drugs like spironolactone and eplerenone and now finerenone slow the progression of renal insufficiency. And one way you can do this actually is to measure albuminuria rather than just looking at the CKD. So this is just work from the TopCat trial that shows you there's a relationship in outcomes as urinary albumin excretion goes up. And what you see here are just different outcome measures, heart failure hospitalizations, cardiovascular mortality, et cetera. Well, when we looked at this, spironolactone was associated with a reduction in the albuminuria. There was a greater treatment effect of spironolactone with greater amounts of albuminuria. It turned out that reducing albuminuria in this clinical trial was also associated with a reduction in heart failure hospitalizations and all-cause mortality. And this was not, frankly, entirely explained by the reduction in systolic blood pressure, because we just talked about how blood pressure will come down over time with MRAs. And of course, now this has been subjected to much larger clinical trial data sets. This is finerenone. I think most of you are probably familiar with finerenone. It's much more specific for the mineralocorticoid receptor than spironolactone or eplerenone are. Therefore, it's also associated with less sexual side effects. You don't have gynecomastia. We also see less hyperkalemia, by the way. And this is one of several trials in this space of using this drug to slow the progression of CKD. This is the Fidelio trial, which complements the Figaro trial, which were trials of patients with both diabetic and non-diabetic CKD and urinary albumin excretion. And they were able to demonstrate that renal outcomes, and renal outcomes, by the way, in a renal trial is dropping the eGFR by 50%, ending up on dialysis or having renal death, was lowered by this intervention. And by the way, this is on top of background ARBs or an ACE inhibitor. So this is in addition to something we do as standard of care. Now, I talked a little bit about this earlier, that there was some relationship with the use of sacubitril valsartan. Many of you know that Paragon HF is a very controversial trial because the p-value in the trial was 0.0056, just barely met significance. But what they were able to demonstrate in the Paragon trial was there was also a decrease in renal outcomes that concomitant with the quote unquote improvement in cardiovascular outcomes. There was also a lowering of renal outcomes as well. And so I'm going to conclude with SGLT2 inhibitors. I don't think anybody can debate that an SGLT2 inhibitor is a renal drug. It targets the co-transporter in the proximal tubule and therefore improves sodium excretion and glucose excretion. And there are a lot of putative effects about how it preserves renal function. It almost certainly decreases hypofiltration in the kidney, which of course helps to prevent the progression of CKD. But there are a lot of other systemic effects by keeping glucose and sodium out of the body. And there is clinical trial evidence that when you give this class of drug to patients with CKD and not heart failure, that it slows the progression of CKD with or without diabetes. And very importantly, when you do that, guess what also happens? You also prevent cardiovascular outcomes. And you can show that the eGFR slope, which is a bit controversial, but at least in nephrology circles, that's flattening the slope of this line helps to preserve renal function. And then, of course, we have HFpEF trials. This is the DELIVER trial, which complements Emperor Preserved, and everybody now knows this outcome, that there was almost a 20% reduction in the combined endpoint of heart failure hospitalizations and cardiovascular death when you give this drug in a randomized placebo-controlled manner. And this is post hoc analysis, but we also saw that in DELIVER trial, just like we did in Paragon, that you not only improve cardiovascular outcomes with this drug, but you also diminish renal outcomes as well. Unfortunately, there weren't enough renal events in DELIVER to really make an impact on that secondary outcome. But when you look at eGFR slope, it's quite clear that dapagliflozin flattens this slope relative to placebo. So let's talk finally about the milieu. I think one of the issues to keep in mind, although we talk about cardiorenal connections, and the heart and the kidney talk to each other really three ways, right? Through the blood vessels, and through the autonomic nervous system. And although this communication is going back and forth constantly, I think it's more important to think about how the kidney is reacting to this environment. Because I think the heart and the kidney are acting in their own ways. They're reacting to their environment in their own specific dysfunction. And for some patients, it's more stiffening of the heart, and in other patients, it's more fibrosis of the kidney. And in some patients, it's both. But it's very unpredictable on how each organ in any given patient is going to react to this environment. But I would tell you, in my opinion, that in HFpEF, what you're seeing is that the kidney is getting beat up more than the heart is. And that's what's resulting in the sodium and fluid avidity. And this is also consistent with how we think about SGLT2 inhibitors. We just talked about it is a renal drug at the end of the day, but there are so many downstream consequences of improving the systemic environment by getting rid of glucose and sodium. We just talked a little bit about that earlier. And in fact, by improving the systemic milieu, by controlling these two factors, that we can see a number of very important effects on the human heart. People talk about metabolic changes, for example, more efficient use of ketones, that's a putative mechanism. But at the end of the day, when you look at SGLT2 inhibitor trials, there is very little change in the heart. There's very little change in the heart. In fact, it's very hard to show a change in LV mass in any SGLT2 emitter trial, whether it's HFrEF or HFpEF. And then let's not forget, perhaps one of the reasons this class of drug is working so well is that it's working as a special diuretic. This is a very small study of only 20 patients done by Jeff Testani. What you see here on the left is the sodium excretion with EMPA in the red and with placebo in the blue. As you can see, there's an increase in sodium excretion, as we all know, and it's augmented when you give this drug on top of a loop diuretic. But what's very important is on the far right. In contrast to diuretics, which do a lot of bad things at the same time as decongesting you, right? Because they stimulate neurohormonal systems and inflammation. In contrast, SGLT2 inhibitors don't do that, despite augmenting the sodium excretion. It's arguably an ideal diuretic. And then, of course, in patients who have, getting back to my story about why were patients hanging on to salt water with an improved ejection fraction, we just published this data from the DELIVER trial. 20% of patients in DELIVER, by the way, had an ejection fraction that was lower than 40%, that was now greater than 40%. And in these patients, you can see the addition of this drug class improved their outcomes. So, this is again something, reason I call this talk an update is because I wrote this in 2016 and suggesting that this was in fact a renal disorder. And I think we now have evidence that the kidney really is fundamental to this problem, and not only targeting the kidney, but targeting the environment that these organs live in is really the key to treating this problem. And so we need to stop thinking about the heart as responsible for everything as cardiologists. I think you've all seen that on the consult service when the troponins up. There are other reasons for the heart to behave badly, and it's not always the heart's problem. So to conclude, I just want to make a case that the cause of volume overload in HFpEF is not clear. In contrast to HFrEF, neurohormonal activation is not universal in HFpEF. Volume overload may be a consequence of primary renal dysfunction. HFpEF may not be a cardiorenal syndrome. I like to think of it as a renal cardiac syndrome. And targeting the kidney and the environment that these organs live in really is now, I think, here as a hypothesis worth pursuing. So thank you very much, and I appreciate it. And love to take some questions.
Great, thanks, James. It's actually a fantastic way of actually turning, sort of HFpEF on its head in a way, so actually looking at the kidney. But I think really, I think as per our discussion earlier, right, it's really a systemic disease, and we just happen to, have a heart as a part of the, sort of a syndrome, but it really is a way of actually looking at the whole body, looking at a whole patient. And I think the crosstalk of the heart, with the kidney is actually a super important aspect that we know is important. And then we know kidney is a window to the health of cardiovascular system. I think that's a great illustration of that. So comments, questions from, yeah, so go ahead. Then the camera will actually focus on you and we know who is the instigator. Yes.
I'll try not to instigate. I really enjoyed that presentation. I really like I try not to make it a long-winded question, but it seems like we're talking about shifting paradigms. And I really relate to your comments about when you started medical training or early staff, that you saw things that you felt were peculiar in the way heart failure was treated. So sometimes I wonder, like when I look at the differences in HFpEF versus HFrEF, obviously these are two different syndromes. And I find that they're different in different ways. Number one, you require an imaging modality to diagnose HFrEF, whereas HFpEF is just a clinical syndrome. So for example, sometimes when I have patients that are really young, let's say in their 20s, that come with end-stage renal disease and they're labeled as HFpEF, I wonder whether they have HFpEF or simply volume overload due to renal failure. I think it's also, it makes me wonder when we talk about the increased mortality in patients with HFpEF, which is a real thing, whether HFpEF is a mediator of increased mortality or just a marker of systemic disease. For example, patients with HFpEF would be older. So when I look at that and I see how do we improve outcomes in patients with HFpEF, I wonder whether we should really focus on switching the definition of HFpEF, maybe requiring an imaging modality like LV mass or a degree of diastolic dysfunction. And if not changing the definition, maybe creating subphenotypes. So, if you have HFpEF because of hypertension or suspected hypertension, then maybe you're a different person than a person who's never had hypertension. Maybe you're a different person if you don't have renal dysfunction. And maybe those patients should be treated differently. Like, in the TopCat trial, if I would have stratified patient based on their aldosterone level, would spironolactone have had a different effect on those that had abnormal aldosterone levels? And then the very last question is, why is TopCat just not repeated again, in North America to see if the hypothesis that was the failure mode is correct, since it seems like it would be a relatively inexpensive trial to run.
Right, so I'll take the last question first. So it is being repeated in Europe. It hasn't been reported out. I think all of us will suspect it is going to be positive. Number two was, although again, get this issue of lumper or splitter, I'm not trying to say that, this issue of creating subphenotypes is not a good idea. This is the issue of trying to get more proximal to the issue, because again, the common final pathway is congestion. So if you're thinking therapeutically, you could either try to get upstream of what's causing renal insufficiency, or you could just deal with the renal insufficiency. Those are just two philosophical approaches. I think most of us would take the latter rather than the former, primarily because, again, as clinicians, primary care and prevention is critically important at a population level, but I think as clinicians, it's very difficult for us to do. So I think that's, if you own a big drug company, I think you'd be thinking about the issue of dealing with the renal insufficiency first, rather than actually trying to go upstream, because it's going to take a trial of 10 or 20 years to actually prove something like that. So.
Yeah, so I think it's a real conundrum when we deal, so I think Juan's question embedded several aspects to it. So maybe we'll answer these questions first, and then last thing I think, just when you have a patient, what are kind of the order
How
of
do we think that,
approaches? Yeah. So Kwang Chan accomplished echographer, but also look after patients as well. So it's atrial fibrillation is a common risk factor in HFpEF. What's the link between atrial fibrillation and the renal function?
Yeah, so there is an association between the two. It's sometimes very difficult to separate the confounding involved because there's so many variables that are associated with both. My personal bias is atrial fibrillation really is a very heart-specific evidence of cardiovascular injury to an inflamed environment. This is why we see so much atrial fibrillation in the hospital in sick patients that are really not necessarily something they're going to have chronically, but we see acutely. And what you do is you see atrial remodeling in that situation. And so atrial fibrillation and its connection to HFpEF is really just a representation of the fever of the heart. And that we're seeing really just another manifestation of the same thing, which is also reflected by sodium fluid avidity in the kidney.
Yeah, so it's actually, yeah, you're absolutely right. I think again, atrium is probably a good readout, right? Of those the systemic perturbation. A comment from Lisa Milner-Chuck, who you know well. Yeah, so head of our heart failure program, and so great talk. Thanks, Jim. And what are your thoughts on novel drugs like MPO inhibitors, but particularly, in terms of your thoughts on the vascular stiffness and microvascular components in HFpEF?
Yeah, no, thank you, Lisa. Great question. You can demonstrate in patients with CKD of all levels of severity, everybody from dialysis to pre-dialysis, that they almost always have measures of cardiac dysfunction as assessed by microvascular dysfunction and vascular stiffness. And so I do think, Lisa, that drugs that are going to improve the renal outcomes will therefore improve the vascular stiffness and the microvascular dysfunction. This is just an opinion, but I think targeting specifically the microvasculature or targeting specifically the vascular stiffness are not going to work in the long term, because again, they are just readouts of something more upstream that's abnormal. And that I don't think you're going to see a clinical outcome difference. I think you might see a surrogate difference. So for example, you might see an improvement in exertional tolerance and maybe quality of life. Not that those aren't important, but I think much more tricky to measure in a clinical prospective trial. I don't think you're going to see really an improvement in cardiovascular death, at least in the confines of doing a clinical trial or heart failure hospitalizations. And that's just an opinion. But although those are operationally important, those are simply readouts, again, as Peter put it. So, but an interesting hypothesis to pursue, that targeting cardiac specific surrogate endpoints could be at least perhaps an early, if you're a big company trying to figure out if this is going to work, if that readout is positive, you might be willing to go to the next endpoint. But I would be cautious.
Yeah. So maybe just a final, sort of a comment for our clinicians. That is that if you actually do see a patient HFpEF on your, sort of on your rounds or on your consult, what is kind of your approach these days?
Sure. So the first issue is diagnosis. We see a lot of volume overloaded patients and the echo EF is normal. That's not necessarily HFpEF. What's really fundamental is you have to have congestion, and I mean central congestion. So you have to have something that you're convinced reflects an increase in circulating volume. So that for me at the bedside, that's JVD. Now, when you have somebody who's morbidly obese, sometimes a little tougher to tell, but not everybody with swollen legs, right, has an elevation of CVP. At Utah, we like to do POCUS echoes, so everybody wants the Everybody wants to do a sonogram of the IJ. That's very popular in Utah now, but that's frankly one way to make me feel comfortable you have the diagnosis. So you got to start there. Number two is that anybody with HFpEF, the diagnosis you have to exclude, remember, because at the end of the day, it's a diagnosis exclusion, is a restrictive cardiomyopathy. So most of us know in most data sets that 10 to 20% of patients you see with HFpEF will have amyloid. So any elderly male with HFpEF has amyloid until proven otherwise. So just keep that in mind too. The clinical signs, by the way, is when you see a very high BNP and even a little bit of troponin when they get admitted. So a BNP, for example, 1,000 in a HFpEF patient would be distinctly unusual, particularly if they're not hypertensive, so you'd have to think about amyloid. And then getting on to treatment, it really is, as I've talked about, decongesting the patient and, you know, use as much diuretic as necessary, and then to keep them out of the hospital, make sure that you're aggressive about managing their volume. A lot of people now put CardioMEMS devices in. You saw the limited data set, but you know, it is true. If you can actually keep their filling pressures down, you can keep them out of the hospital. In terms of improving quality of life and outcomes, I think now the standard is SGLT2 inhibitors. It will be it's a class 1 in the European guidelines. It's class 2 in the American guidelines, only because in the American guidelines we didn't have it at the time. But it's going to really form the foundation. And I always use MRAs. I think the drug is really inexpensive, underutilized, et cetera. So I always put my patients on SGLT2 inhibitors and MRAs. We can talk a little bit later about sequencing, which first, you know, what do you do when the creatinine bumps? But that's probably a conversation that's going to take a little bit longer.
Wow, that's fantastic. Yeah, it's really actually a great summary of really, you know, both the science, the evidence, and also, you know, the practical aspect. So I think this is why, you know, everybody wants Dr. James Fang, you know, for the heart failure programs. And so we are really privileged today to have you, you know, to come all the way from Utah to join us today, and also look forward to, you know, today's conversation with our trainees. And so thank you so much on behalf of the entire community.
Thank you.